Hey, welcome everyone to the October Learning Health System or LHS seminar series. I'm Saumi Amayapin. I'm the manager of the Learning Health System here at Women's College Hospital, and I'm pleased to soon introduce our October speaker. In the meantime, just wanted to remind you all that we do have recordings from our previous sessions on the link above on the screen, and we can share that link in the chat as well. If we move on to the next slide, I'm happy to introduce our topic is on population health for chronic kidney disease or CKD. And our speaker, Dr. Manisha Jhamb, who's actually joining us from the key battleground state of Pennsylvania. So Dr. Jhamb is an associate professor in the renal electrolyte division at the University of Pittsburgh. She currently serves as the associate division chief and director of the Center for Population Health Management. And she's also the co-director of clinical research in the renal electrolyte division. She also co-directs the UPMC, the University of Pittsburgh Medical Center Health Plan CKD management program that's using a population health management approach to improve CKD care delivery across the health system. So lots that we can take away here. After completing her medical school training in India, Dr. Jhamb did her master's in public health at the University of Texas in Houston. She then completed her residency from West Penn Hospital and her nephrology fellowship from the University of Pittsburgh. So she's an established clinician scientist and health services researcher with an interest in testing interventions to improve CKD care delivery, patient-centered outcomes, and quality of life in kidney disease. Finally, her work has been funded by the National Institutes of Health and the American Heart Institution. So welcome, Dr. Jhamb. Thank you so much for joining us. One more quick reminder, folks, is that we do have actually an evaluation we'd like you to complete at the end of the session. We'll leave the QR code for a few seconds up here. And at the end of Dr. Jhamb's talk, we will share the link to this evaluation form in the chat as well. So if you want to just take a few moments to capture this QR code, but not to worry, it will be available at the end of the talk. Okay. Thanks very much. Okay, we can stop sharing, and I'm happy to hand it over to our speaker, Dr. Jhamb.
Thank you, Soumya, for a very kind introduction and invitation to present at this seminar series today. I'm really looking forward to an engaging discussion and learning from all of you. So I'll present some of our work that we've been doing and how we've learned from our mistakes and tried to improve. And then that is, I think, at the center of like a learning health system. All right, so you should be able to see my screen now.
Yes.
Okay, perfect.
That's great. Perfect.
So I'm going to talk a little bit about some of the challenges in improving chronic kidney disease care, and then some of the strategies that we've taken to address these challenges, and how we've used a multidisciplinary population health management approach in our system. So just to start off with some background, why do we care about chronic kidney disease? I think this is one of the highly costly diseases that's affecting our healthcare systems. And it is a silent disease that's causing a heavy burden on our patients. And as we are seeing more and more people with diabetes and hypertension, especially in the Western world, we are going to see more chronic kidney disease. Also, as our population ages over the age of 65, 40% of our patients are expected to have chronic kidney disease. In kidney disease, most people don't realize like it kills more people than breast or prostate cancer every year. And the reason for this is that chronic kidney disease is a cardiovascular risk equivalent. So these people have a lot of traditional risk factors for having cardiovascular disease, but also a lot of other CKD specific risk factors, including inflammation and hypertrophy and those kind of things that can increase their risk of cardiovascular disease. And this is a slide showing that it is the seventh leading global cause of death. And as you can see, the kidney dysfunction is the red bar on here in the chart. And after high blood pressure, smoking, high fasting plasma glucose, air pollution, high BMI, high LDL, next one is kidney dysfunction. And all of these disease states that are ahead of kidney disease are risk factors for kidney disease. And unfortunately, there are large gaps in evidence-based care for CKD. This kind of circle shows you proportion of people with CKD awareness of their diagnosis. And the red part is that 80 to 93% of people are unaware that they have chronic kidney disease. And of the few people that have awareness of chronic kidney disease, there's a lot of missed opportunities to get them on the right treatment. So for example, proteinuria monitoring, it's only done accurately in 50% of the patients. Blood pressure and diabetes control remains suboptimal. The RAS inhibitor use, one of the things that we have in our toolbox, these are cheap and easy, have been around for decades. Even those not all patients who should be on them are on these medications. And SGLT2 inhibitor, it's the one of the latest of one of three drug classes for chronic kidney disease that we have now. We have to do a lot of work to implement this in clinical practice. And I think there's a lot of excitement in the nephrology community. SGLT2 inhibitors are one of the three new drug classes. This slide shows the expected benefit from SGLT2 inhibitor. On the x-axis are years from starting somebody on these medications, and this is data that's extrapolated from one of the large trials, Credence trial. And then on the y-axis is the eGFR. So if you have a patient who's on these traditional medications, that's the RAS inhibitor, that's the yellow dotted line, you see this fast decline in the eGFR over time as compared to somebody who's on an SGLT2 inhibitor in addition to RAS, and that's the blue dotted line. And the SGLT2 inhibitors gone for an additional 15 years of freedom from end-stage kidney disease. So that's huge for our patients. And I think this is the kind of data that we've now seen from all the drugs in SGLT2 inhibitor class. There's also some very promising data from GLP-1 receptor agonist and from non-steroidal mineralocorticoid receptor antagonist. And as you can see, these are now part of the KDIGO guidelines for management of chronic kidney disease. So at the bottom of this pyramid, the first tier is our lifestyle and self-management strategies. But then if you look at the medications, SGLT2 inhibitors are in the first line drug therapy, and then GLP-1 RAs and the non-steroidal MRAs are in tier 2. So these are newer medications, excellent benefits, and now it's our responsibility to try to make sure all our patients are on these correct medicines. And there's this implementation gap that's well known in health services research. This is the timeline for research to translate to practice, and it's the crossing the valley of death. And it's said that it takes almost 17 years from the time when something shows evidence based on research studies for it to actually get into clinical practice. And I think it's a shame that it will take 17 years to get some of our patients on these medications, which can save lives and improve their quality of life. And I think that's where now the whole nephrology community and all health systems need to really focus their efforts on. There have been some nice review articles. This is one of them that I show here that are talking about barriers in implementing some of these new cardiorenal therapies for chronic kidney disease. And some of these barriers are related to, so I'll start at 12 o'clock position and start going clockwise. So clinical inertia, low awareness, this is both for patients and providers. Suboptimal education, this is mainly for patients who don't even know they have chronic kidney disease, which also leads to lack of engagement. In terms of these patients' complexity, these are highly complex patients who have multimorbidity and polypharmacy and challenges in primary care because of competing demands. And it can get really difficult to implement some of these newer guidelines to manage these patients. On top of that, a lot of times these patients have fragmented care, and there might be health disparities that are especially health insurance affordability, prescription drug coverage cost that are really important in limiting access to these treatment options. And then lastly, policy-focused issues on equity and high drug prices are some of the other barriers on a national level. And I think if you think about the primary care provider, there's a lot of steps that go into first deciding whether a patient has CKD and then deciding the correct uh, management steps for that patient. So again, starting at 12 o'clock, first you have to find out, yes, this patient has CKD or not. What is their risk for end-stage kidney disease? You have to figure out, you have to assess that patient, order EGFR and UACR. Once you get those results back, interpret where on the heat map for CKD staging do these patients fall into to prognosticate how severe their disease is. And then you have to evaluate what are the risk factors, how can you decrease the progression to end-stage kidney disease, and then identify areas for target. So you can suppress proteinuria, control risk factors, and then take an action to prescribe these medications, educate the patient, and then implement, and then the circle keeps going because you have to reassess after assessing patients' response to treatment and tolerance of that treatment. So this is a complex process with potential for lapses at each of these steps. Moreover, patients with chronic kidney disease are highly complex. This is a very nice article that looked at uh, patients who are being seen across different specialties. On the first graph, they're looking at the number of comorbidities these patients have. And if you look at the nephrologist, that's the top bar. So the patients that a nephrologist is seeing have a mean of 4.2 comorbidities, and it's highest among all specialties. On the right side of this slide, it shows the prescribed number of medications. Again, patients who are being seen by a nephrologist have a mean of 14.2 prescribed medications, highest among all specialties. So these are just really complex patients. And one is you're worried about polypharmacy or hyperpolypharmacy in these patients, but then also worried about drug-drug interactions, side effects from these medications, and just the patient burden of taking all these medications, especially when they don't even know they have kidney disease. So 90% of our patients don't know they have chronic kidney disease. And what's really surprising to me is that even among those with stage 4 disease, less than half of them are aware. And what ends up happening is most patients never see a nephrologist. They're not prepared for dialysis, kidney transplant, or have discussions around conservative management or medical management without dialysis. And many patients end up with a crash start dialysis in the hospital with a dialysis catheter and have poor outcomes. And we all know that older patients experience more morbidity and mortality after starting dialysis, and especially in these patients, that early interaction with a nephrologist or a specialist team is really important to understand their values and preferences, because in most cases, dialysis becomes the default pathway if there are no such discussions ahead of time. So, what can we do about changing the landscape of chronic kidney disease management? There's been a lot of these recent manuscripts that have come out that talk about multidisciplinary care team roles, how they can improve patient outcomes. And these programs involve pharmacists, nurse educators, dietitians, social workers, and they can all work together to improve patient outcomes, increase patients' self-efficacy for managing kidney disease, and provide support to the primary care providers who are trying to take care of these highly complex patients. And I think in my mind, population health management is a way to address, uh, is one of the strategies to address the challenges that we see in chronic kidney disease and incorporate this multidisciplinary team model. So, what is population health management? Population health management is something when you're looking as a health system as at your entire population, and then essentially defining the population of interest, and then risk triaging or risk stratifying your population to find out who are those patients who need the highest, most resource intensive support systems and resources, and then identify care gaps amongst those patients, and then develop and implement clinical services and care pathways, engage providers and patients, and measure outcomes and your key performance indicators and return on investment. And this is a continuous uh, quality improvement cycle that has to continue um, learning from how things are going, adapting to changing needs of the health system, of the providers and patients, and then reevaluating what are the metrics that indicate success. And I think with the leveraging electronic health records gives us a great advantage to do this. We can now phenotype patients and risk triage them using a lot of the prediction tools that exist out there that can be incorporated in real time in EHR. And also a lot of the clinical decision supports, telemedicines, and e-consults that can be supported by EHR can really help standardize workflows across a health system. So just to dive a little bit more into this population health management. So based on the EHR data at the as a first step, we can implement some risk prediction algorithms to help the PCP identify who are the patients who can continue to follow up with the PCP and who are the patients who need to be referred to a nephrologist. And then give them some tools. So for patients who are going to follow up with the PCP, provide resources, including like e-consults and pharmacist support to help the PCPs and at the same time provide resources to the patient, including education, dietitian support, social worker support, and very importantly, renal palliative support. And I think this is a model where population health management plays out really well. And part of the reason is because CKD is such a lab-based diagnosis that we can use EHR to find these patients. We can use EHR to identify where are the care gaps, especially if like patients are not on some of the uh, guideline-based medical therapy, and then identify and target our resources towards those patients. So we used this approach and tested it out in a large trial called Kidney Champ. The goal of this was to provide specialty assistance to the primary care providers without the office visit. This was an NIH-funded randomized controlled trial that we finished in 2022. And practices were randomized to either receive the K-CHAMP intervention versus usual care. One of the advantages that we have in University of Pittsburgh Medical Center is that we have a large number of practices that fall under one umbrella. They all use the same EHR. So we were able to randomize these practices. So we had about 100 practices randomized with over 300 PCPs. Our primary outcome was progression to end-stage kidney disease or a 40% decline in eGFR. And we were looking at a large number of secondary process-related outcomes, like hypertension control, use of RAS inhibitor, medication safety, especially looking at NSAIDs and metformin with the correct dosage. I have to remind everyone, so we started this trial in May of 2019. When we were designing this trial or writing the protocol, SGLT2s and none of these other classes were in the play. They were not part of guidelines. And so these were added on as exploratory outcomes later in our trial. So this is kind of our thought process of how we incorporated multi-level approach and multidisciplinary team in the model. We identified early on that there were care gaps at the health system level, at the primary care provider, and the patient level, and we needed to address all these care gaps at all these three levels. So at the health system level, the care gap was that we were doing a poor job of identifying patients who have a high risk for progressing to end-stage kidney disease, and we had limited support for PCPs to manage these complex patients. So how we addressed this was we built EHR-based risk stratification. So I'll talk a little bit more about this. We built a lot of dashboards and reporting tools in our EHR, and then we built clinical decision supports. At the primary care provider level, we realized there was therapeutic inertia, there was lack of knowledge, suboptimal medication management, and late referral to nephrology. So the intervention was designed to co-manage and provide support to PCPs via e-consult and via pharmacist-led medication management. And then we continued regular academic detailing and outreach to primary care providers to increase their knowledge about PCPs, their prescribing confidence. And this actually turned out really important because during the study, there was a lot of new evidence that kept coming out. And starting in January of 2020, a lot of the guidelines started changing, starting with the American Diabetes Association guidelines. So this became a really important aspect of this of our approach. At the patient level, we talked about patient unawareness or really understanding why CKD is important, and then care fragmentation. So we really emphasized a lot in our educations about the importance of CKD and help patients with care coordination when needed. So just a little bit about UPMC. So University of Pittsburgh Medical Center is a large healthcare organization in primarily in Western Pennsylvania. It has 92,000 staff members. It has 40 academic, community, and specialty hospitals, and then about 350 primary care providers that come under this umbrella. It is also part of an integrated delivery and finance system, which means that it has its own health plan or health insurance plan, which has about 4 million members. So this gave us a unique opportunity to try this novel value-based model of care. For risk stratification, for our to find out who are the high-risk patients amongst all CKD patients, we first created a CKD registry with all patients who had a recent eGFR of less than 60. And then we characterized these patients at high risk versus not based on the 4-variable kidney failure risk equation. And then, as you can imagine, like a lot of our patients had missing urine albuminuria, and we were not able to calculate the KFRE equation score. And to kind of circumvent that issue, we built an internal machine learning-based prediction model, and we targeted the top decile risk amongst those patients. This is a snapshot of how our dashboard looked like. So this was a single page view of all our patients. So the nurse manager who was looking at this monthly could look at it, sort these patients based on their 2-year or their 5-year risk score, could look at whether they had a nephrologist appointment in the past or they had an upcoming nephrologist appointment. And this was important because if a patient was already seeing a nephrologist, we were not interested in them because the goal was really to identify patients who were not under nephrology care already. So And then you could highlight any single patient on this and have a more detailed view of like what their EGFR was. This was important to make sure we're not capturing AKI, like transient drops in EGFR. We really wanted patients who had uh, chronic kidney disease. And then we could look at all their therapeutic medications and potentially nephrotoxic medications on one screen. So our intervention approach um, was built on uh, some of these things that we really leveraged EHR for. One of the big things was e-consults. And these e-consults were a special type of e-consults. These are called TACOs, or targeted automatic electronic consultations. And here, targeted means that these were targeted for high-risk patients who were not already seeing a nephrologist, and these were automatic. Automatic means these were triggered not because like the PCP solicited the e-consult, but we found these patients, and unless the PCP or the patient opted out, we put an e-consult in the chart for the PCP to see. The patients also got a medication therapy management by a Form D, CKD education. Again, this education initially was opt-in, and we had poor uptake of this, and we changed it to an automatic opt-out approach. So unless the PCP or the patient opted out, our nurse educators reached out to the patient and talked to them about CKD. And then it was really important for us to continue PCP outreach and engagement, not just for education and feedback, but also uh, the nephrology team was only providing recommendations to the PCP. Ultimately, it was the PCP's responsibility to prescribe and order those medications. So we really needed their support for this. We really worked hard to align the workflow with the PCP's workflow, and we had a lot of PCP leadership stakeholders in the planning phase that helped us work out this process. So we were looking at patients' upcoming PCP appointment about a month in advance. Our nurse would review the chart and looking for patients who meet our eligibility criteria in terms of having a high-risk CKD and not seeing nephrologists within the last 12 months. And then at that point, we would send an EPIC in-basket message to the PCP, and a letter was mailed out to the patient. And this was our way of giving both the PCP and the patient a chance to opt out. If they did not opt out, then we proceeded with the rest of our workflow. And that included about a week before the patient's appointment, we would do a nephrology e-consult, and our pharmacist would call the patient and do a medication therapy management. And we would have both these notes put in the patient's EHR, patient's chart in the EHR. And then right after the PCP appointment, our nurse would reach out to the patient and do an education session. So these are the results of our trial. So we enrolled 1,596 patients from 98 PCP practices. So we reached our recruitment target. We had a median 17-month follow-up. In terms of some of the baseline characteristics, the things I want to highlight are in red. So our mean age was about 74 years. So an older population. We had very good representation of women. Our average EGFR was about 36, 37, so late stage 3B patients. Our median UACR was about 85, so mostly microalbuminuria. Our 5-year KFRE score was 4%. And then in terms of like medication use at baseline, about 45% of our patients were already on RAS inhibitors. As expected, SGLT2 and GLP-1 use at baseline was minimal. And then about 50% of our patients were on moderate to high intensity statin at baseline. So these are our results. Over a median follow-up of 17.4 months, there was no significant difference in rate of our primary outcome between the two arms. So again, the primary outcome was progression to end-stage kidney disease or a 40% drop in eGFR. And the graph here shows the cumulative probability over time. And the blue here is the kidney champ intervention, and the red dot here is the control. So for progression to or end-stage kidney disease, no difference. We also looked at death, and there was no difference. And then we looked at a composite outcome of progression to end-stage kidney disease or death, and there was no difference there either. And then this is, we did see that patients in the kidney champ arm compared to usual care had increased exposure to RAS inhibitors by about 21%. We've done some additional analysis that I think is actually very exciting. Um, this is um, this is a manuscript that just came out in JASN last week. We were looking at guideline recommended medication therapy in patients in the kidney champ versus usual care. And we showed that our intervention increased SGLT2 inhibitor exposure days and GLP-1 receptor agonist exposure days to about 1.5 to 2.5 times in the kidney champ intervention arm. And I think what was interesting is when we looked at time trends over time, these graphs show the left side shows SGLT2, the right graph is for GLPs, and on the x-axis are the years from 2019 all the way to 2022 when the study ended. And then on the y-axis are percentage of patients with active medication use. And here kidney champ is orange and blue is the usual care. So over time, we did expect the usual care arm to have increased use of these medications based on secular trends, what was going on with new guidelines coming out and with the cost of these drugs going down. But what our intervention was able to do was really increase the use of these drugs and get these patients on these drugs earlier and at a higher percentage. So by 2022, about 44% in kidney champ were on either of these medications versus 27% in the usual care control arm. One of the other things that we were really interested in seeing was medication therapy problems. Oh, sorry, I forgot to mention this past work. This is being led by two of my mentees whose pictures are up here. Melanie Welkman, she's a PharmD, and she's a research assistant professor with us. And Linda Marie Lavenberg, she is a nephrologist who's also an assistant professor and helping with this work. The next piece of this was medication therapy problems. So just to get everybody on the same page, medication therapy problem is an undesirable event experienced by a patient that involves or is suspected to involve drug therapy and that interferes with achieving the desired goals of therapy and requires clinical judgment to resolve or present. So, a lot of times when we think about medication therapy problems, you're thinking about a patient is on a wrong dose, or there's a drug-drug interaction, something on those lines. But one of the key things that is also part of an MTP is if there is an indication for a drug and patient is not getting that drug, that is one of the key MTPs that actually was one of the most important ones for us because on this graph, needs additional medication therapy. That's the top bar. The green and blue represent patients who received a phone medication review versus a chart review. But in both those cases, we identified this new need for a drug. And this was because of the evolving guidelines during the study, and the drug that most commonly was indicated was an SGLT2 inhibitor. And then we identified suboptimal medications, and the most common one was NSAIDs. A lot of our patients were on it. We identified dosage issues, especially for metformin and H2 blockers. And then drug interactions. Usually these were when a patient was prescribed a statin and a fibrate, or statin and a calcium channel blocker. And then unnecessary medication therapy, especially with PPI, was one of the most common ones that was identified. And Melanie led this work and has presented this as an NKF um, poster, and this is under peer review right now. We also conducted an ancillary qualitative study because we were very interested in getting provider and patient feedback on what they thought about this kind of intervention. And we um, we interviewed patients who represented some of our minority patients, and we tried to recruit a very diverse group of providers. Amongst the patient interviews, there were certain themes that came out. And one was that patients expressed support for the dual goals of Kidney Jam, which was helping their PCP co-manage their disease along with a nephrologist and helping the patients. But despite the support, participants exhibited a poor understanding of cause and health risk associated with CKD. And patients' understanding of CKD was linked to their impression of the CKD education they received. And the figure here is trying to show, these patients were at very different levels. There was a big variety in the knowledge, self-efficacy, and what they thought about um, the options that existed out there for CKD management. And a lot of patients knew that CKD leads to kidney failure or dialysis. They had heard about the word dialysis and they were scared about that. But then the intervening pathway, they did not know how bad their disease was, when will they get to dialysis, what their CKD stage was, or what were they doing, or what was their doctor doing to help them manage their kidney disease. So I think one of the takeaways for our team from this was that um, we really need to tailor the CKD education uh, to the patient's health literacy level, their insight, and then probably um, have more frequent versus less frequent touches with patients that are more individualized based on their needs. And this was work that was presented at an ASN conference by Linda and Susan Deverarch, who was in my lab as a postdoc. Linda also led some of the work looking at PCP interviews, where we were trying to find out how PCPs felt about this e-consult that was unsolicited. It landed in their inbox, and now they had to act on it. So there were 4 themes that kind of came out. Theme 1 was that PCPs favored this e-consult format because it addressed barriers to nephrology and limited specialist availability. Theme 2 was PCPs really valued the team approach, especially with uh, the pharmacist and the nurse educator. They believed this was really beneficial. Um, Theme 3 was also quite positive, but PCPs did feel that it may not be the appropriate method for all patients with CKD, and e-consults may need to be tailored to individual patients. And theme 4 was some PCPs were dissatisfied with the burden of implementing recommendations and wanted more concise notes. So these were really good learning points for our team. So I want to take a step back and kind of um, pause here and think back, like what were our lessons and why was KCHAMP not effective in improving our primary outcome? So we've thought this in a few different ways. One of the big things was like when we were doing the study, COVID-19 hit, and there were a lot of challenges in primary care, more so in specialist offices. Primary care offices, like the focus shifted to acute care and acute illness and vaccination and helping patients with actually some of the social challenges. And then chronic disease management took a backseat. Also, because of COVID-19 pandemic, we uh, ended up with a shorter than planned follow-up period, and we had a higher competing risk of death. And that resulted in low event rate for our primary outcome, and maybe that's why we did not capture um, many events. Also, the overall exposure to these newer medications was very small. I mean, we did show that the uptake increased by almost 2.5 times, but the overall exposure was only zero point 0.3 years. And a lot of these recent trials on these new medications were 2 to 3.5 years long. So you do need a longer exposure to these medications to see their benefit. Um, we might have had a limited impact on PCP prescribing behavior. That's one of the hardest things to change, and their therapeutic inertia, and also low prescribing self-efficacy, especially when we were asking them to prescribe, for example, SGLT2 inhibitors in non-diabetic patient. This was something that was really new for them. They had a lot of questions about safety, and I think this was evolving as the study was going on. And I think limited impact on patient behavior might have been one of the reasons, again, because of lack of patient awareness on CKD as a disease priority. So I'm going to switch modes a little bit now. I've talked to you a lot about what the challenges in CKD were, what we did in the trial, and what the results of the trial were. I want to switch a little bit about how we've taken all of this, the experience, and um, try to evolve on this as in our system. The learning health system is defined by National Academy of Medicine as a system in which science, informatics, incentives, and culture are aligned for continuous improvement and innovation, with best practices seamlessly embedded in the delivery process. Patients and families, active participants in all elements, and new knowledge captured as an integral byproduct of the delivery experience. So I think this is something that we have tried to uh, really emphasize in our system and embrace. And um, over the years, we have tried a number of strategies to improve CKD management. And I'll start with this one. This is a prior attempt in our system. This was a small randomized controlled trial where we built these clinical decision supports for the PCPs. And basically, this is saying this patient has this eGFR less than 45 and no UACR. Please order a UACR, and then please consider referring this patient to nephrology. And essentially, this was a negative trial. So we were not able to change provider practice based on this clinical decision support. And I think based on some of these past experiences and experience with Kidney Champ, we we developed this new value-based model of CKD care, in which we built a lot of EHR infrastructure. Like I showed you, we built in the kidney failure risk equation that was inbuilt into our EHR, which helped us risk stratify. We built a lot of clinical decision supports and dashboards and a patient portal. We built a strong clinical infrastructure with a lot of ancillary support through nurse educators, pharmacists, dietitians, social worker, and renal palliative clinicians. And on the back end, we are using a data-driven approach to constantly evaluate how we are doing. Some of the stakeholders that have been integral to approval of this kind of a process, leadership buy-in. We had buy-in from primary care provider, our UPMC health plan leadership, nephrology and hospital leadership, local nephrology champions, including my boss, Dr. Clayman, have been very important in making sure like higher ups like learn about CKD, why it's important for them to address CKD. We had a lot of buy-in from our health IT team to build all the IT infrastructure, compliance and legal teams and regulatory teams to make sure we are following all the rules, and the finance team to make sure what we were doing was okay. In terms of the implementation steps, the way we went about it was first identifying stakeholders and getting their buy-in, aligning to institutional goals and priorities. I think this was very, very important early on, where the health system, uh, we had to really get the health system leadership engaged and excited about why this is important and how this is going to be good for the health system and for the health plan. Um, like I mentioned, we spent a lot of time in developing some of these IT tools, including the CKD registry, and developing workflows and protocols with input from primary care providers and IT. We did pilot testing in a few PCP practices, got their initial feedback, and then refine and revamp the program, and then really try to create this central team of highly experienced people who could leverage telemedicine to cover a large geographical area across the health system to offer these kind of services. And then constantly engaging the PCPs, and then using a data-driven approach to monitor our operations and reevaluate our metrics for success. Some of the things that we learned from KCHAMP that did not work well, we tried to enhance in a new program. This is the K-Care, Kidney Care program. And some of the enhancements that we did, first limitation was we felt there was limited impact on PCP behavior. So we did a lot more academic detailing, case-based experiential learning through e-consults, uh, especially with the newer therapeutics, we gave them very individualized recommendations. We improved the e-consult documentation, readability and ease of use, and enhanced pharmacist support. To change the patient behavior, again, a lot of emphasis on individualized educational materials. So, for example, we use the CKD report card that has been developed by NKDEP, which has the patient's eGFR and blood pressure. We talk to the patients about benefits of these newer medications and ask them to talk to their doctors about it. And then we incorporated renal dietitian in our team. One of the things that really came out in this post-pandemic era was the need for addressing social needs, like medication assistance, food insecurity, and transportation. And to address this, we incorporated social needs screening and captured these through the EHR, and then incorporated a renal social worker. And then lastly, to align care with patient values, we incorporated advanced care planning screening for all patients, and then incorporated discussions with renal palliative trained clinicians, especially for our older and frail patients. We leveraged some of the successes from Kidney Champ, for example, using this multidisciplinary bundled intervention, using our dashboard prediction tools, leveraging telemedicine, using an opt-out approach. So those were things that were successful with KCHAMP, and we leveraged those to expand this program. And to me, what was really important was this last bullet point was that we were able to scale up this program and provide equitable and resources using this highly trained central clinical team. And we were able to provide services to a wide geographical area, including rural areas. And 24% of patients in Kidney Champ were rural patients. So this kidney care program, over a 3-year period, we established this multidisciplinary team with 13 full-time effort people working in this team, and scaled it up to 102 PCP practices. We enrolled 3,000 patients, and once a patient was enrolled, we followed them every 6 months. And we did over 6,000 e-consults, about 5,600 medication reviews, and almost 5,000 education sessions. Our renal palliative clinicians worked really hard and 141 patients ended up choosing medical management without dialysis. And out of the patients who got social worker support, about half of them were for medication assistance and 1/3 were for home services or transportation. So I think in the end, I would say this population health management approach is an approach which I think can identify patient subgroups, disease states, and processes of care that can improve timely implementation of evidence-based care and standardized care across a large health system, um, and start to address some of the health disparities. There are some challenges, and these are areas of future research. One is, how do we make sure it's not one size fits all? It has to be personalized medicine. We also have to think carefully about metrics, especially for CKD related programs, because some of the outcomes for CKD take years to change. For example, the GFR. And sometimes you need some early metrics to see if your program is making a difference or not. And then I think in the end, this value-based care financial model, um, especially with the healthcare model in the US, I think that becomes really important in terms of sustainability of such a program. So I'll end here. This is our team in action. We have some people on the screen there in a hybrid format, but this was our wonderful team who worked on this program, and then this is my research team, and you see in the back the Cathedral of Learning, which is one of the landmarks of University of Pittsburgh. So I'll end here, and then happy to take questions.
Thanks very much, Dr. Jhamb. That was a great talk. I think from our perspective, and as we're developing our learning health system, it's really great to hear some of the lessons learned and kind of how you work through those processes, especially as we think about getting buy-in and determining the infrastructure we need, but also patient education being such an important piece too. We'd love to open up the floor to any questions. I see Ruglan physically put up her hand. Can go
Yeah.
to you first.
Very old school, yeah. Manisha, thanks, that was so interesting. I wanted to ask, since the paper came out, and what has been the uptake? Because again, huge amount of effort, huge amount of teams, lots of infrastructure got put in place. But what has stayed and what has been able to get funded in order to be able to maintain it? Because even though you showed it was negative, there's still some benefits that may be down the pike. So I was just wondering, and also any other post hoc analyses that you've shown that there's potentially a benefit?
Right. So, initially this was funded by the NIH, but then what was really heartening for me was that I think even before our results were out, like people recognized the importance of this, and we formed a partnership with our health insurance plan, and they funded this program for 3 years, and they put in a lot of money into building up all the infrastructure that I mentioned. And I think we are at a point we're trying to figure out in this financial climate, what is the sustainability for such a model? In the US, this purely value-based model of care is very hard to sustain, especially when some of the return on investment is so downstream. Like to get these patients to even see a benefit of somebody on an SGLT2, it will probably be 2 or 3 years time. And there's no shorter outcomes. Like for a diabetes, we have a similar diabetes program. And for that, it's easy. Like HbA1c, you can show a change in A1c in 6 months, but you can't show that with eGFR. So I think that becomes the challenge.
And ongoing things that you're gonna keep like that now that the trial has ended, you've got the results, like what are the things that'll stay and what are the things that are gonna go?
I think we're trying to figure out a way to do this more efficiently and uh, keep them, I think, streamline our resources. I think one of the things that we really found useful was involving APPs to help us do the e-consults, and that really helped save the nephrologist time and the budget.
And because it's a
So,
Canadian audience, you gotta tell everybody what the acronyms stand for. What's an APP?
advanced physician provider.
Okay.
So instead of a physician doing these, we had advanced physician providers who were reviewing the patient's chart, and then they would meet with the physician and the pharmacist to come up with recommendations for the PCP. So that was a cost-effective way of doing the e-consults.
Got it. Okay. Thank you.
Let's go to Daisy, and then I'll read a question from the chat.
Thank you for a great talk. I was just wondering about the logistics of doing the cluster randomized design. How did it work for your consent process? Was it sort of automatic, or were you consenting individuals, or I might have missed it?
That's a great question. And because of the pragmatic nature of this, like we could not do individual consents.
Right.
So the way we did it was like this was a quality improvement project because we were not testing any new therapies. We were rolling out, this is health services research. So we gave people the option to opt out. So
Right.
the patient got a letter mailed to their home and the PCP got a message in their inbox, and they both could opt out. But if they did not, it was implied consent.
Implied. And sorry, can I ask one other question? It just related to the outcome. You know, you alluded to the fact that the EGFR might have been maybe not the right outcome for the time period. What other outcome do you think might have been better? Because it can be really hard. You know, does early intervention, I guess, like does going to see a nephrologist sooner or more appropriately, does that necessarily, you know, would that move that marker, I guess? Is there any evidence to suggest that? Or is there something else we're trying to move?
I think you could look at some of the process of care outcomes,
Mhm.
and those were some of our secondary outcomes like hypertension control or A1C control.
Mhm.
Or you could look at whether the patients are on the right medications.
Right.
So for things that are cheap and generic, that works. But for SGLT2s, for example, I think that's a difficult outcome because PCPs might have prescribed it, but if the patient cannot afford it or has insurance issues, then they're not taking it. So then it's not the right outcome marker for what you're trying to study. So I think that's where I get stuck at is like, what is the right and shorter term outcome for CKD? And I think that's the challenge.
Mhm.
I know we're at time. If we can squeeze in one more question for those who can
Sure.
stick around. There is one in the chat from Dr. Blanca Bolea about what your opinion is on the future machine learning prediction models in healthcare. What are the challenges and gains?
Yeah, I think there's a lot of potential for something like predicting who are these patients who are going to be at high risk of poor outcomes, finding these patients. So the risk stratifying part for sure. I think even reviewing the patient chart, coming up with some templated recommendations for the patient, for the provider. I think some of these machine learning models can do that, but I think there has to be some element of physician oversight because there's that art in medicine, I think, which machine learning or like these templated clinical decision supports may not be able to capture. So what we tried to do with the e-consult was really dig into the patient's chart and try to capture some of the things which are not evident, right? What is the patient's functional status? Is there some like preferences that they've mentioned that this is a patient who would never take injectables? They're okay taking oral medications. What is the patient's other kind of preferences and values around how aggressive care they want to be. I think some of these kind of things, that's where we really needed somebody to extract this kind of information from the chart, which is not evident otherwise in like structured EHR fields.
Thank you. Thank you again, Dr. Jhamb, and thank you for everyone for joining us. So our next seminar is scheduled for December. Please look out for a notice. It should be in your calendars. And want to thank Dr. Jhamb again for taking the time to share this great presentation and the amazing work that you're doing in Pittsburgh. Thank you.
Thank you for having me.
And we'll see you shortly in the post-seminar chat. Great, thank you.